On behalf of the Patient Safety Authority, I would like to welcome you to the webinar titled Healthcare Serial Murders, Patterns, and Challenges. My name is Kelly Gibson, and I will be your moderator for this program. We welcome any comments or questions. All materials are provided for your educational use. Now I'd like to introduce our speaker for the webinar, Zane Robinson Wolf, Dean Emerita and professor at the School of Nursing and Health Sciences, Salle University, is a member of the St. Christopher's Patient Safety Committee, the Board of Patient Safety Authority Patient Safety Journal, and editor-in-chief, Emerita, the International Journal for Human Caring. I will turn the presentation, Zane, over to you now.
Hi, Kelly. Thank you very much for introducing me. Today, I'm going to present Healthcare Serial Murders, Patterns and Challenges. So the objectives are to really look at that murder by healthcare professionals is an important, significant patient safety threat. We're going to look at some of the cases of people who are healthcare providers allegedly or convicted of murder, and examine some of the motives that have been described related to healthcare provider serial murder, and then hopefully look at some of the empirical indicators, more factual indicators that suggest that maybe there are patterns that we need to pay attention to, especially some statistics and also failure modes and effect analysis by safety teams in healthcare organizations. So one of the reasons that I began to study murder will become apparent, especially related to healthcare provider murder. We're all very comfortable, I guess, with some of the crime programs that we see really on TV. There really are, there are quite a lot of them. And when I was talking about a study that I did with a couple colleagues on healthcare provider murder, one of my extraordinarily talented nurse colleagues said, "Why are you doing this, Zane?" I sort of thought, well, perhaps she thinks I'm trying to be sensational about this. But my answer was that it is an extraordinary safety threat because it ends people's lives, people who are very vulnerable. And the vulnerability idea will come up again and again in this presentation. And when I first began to be aware of this, I was conducting my first qualitative study in medication errors because part of my dissertation had been to do observational research on one of the ritual categories of nurses administering, medications. And by doing the literature review, and this was sort of about 1986, 1987, I found 3 articles that convinced me that there was a problem there. And the 3 articles were in the medical literature, and the earliest one was 1976, and then the next 2, 1985. And in all 3 cases, nurses were indicted. Allegedly, they were murderers. And the descriptions of what was going on in terms of the data collected really showed me early on that there were problems with data collection. But when you look at the date 1976, you should say to yourself, why haven't we gotten our arms around this to the present day? So obviously, anything that deals with healthcare crime and neglect by healthcare providers is on the dark side of healthcare systems among its workers. Providers are in a power position, and that people who come to us for care expect both professional and humanistic or caring behavior, so that any kind of crime or neglect is a contradiction with caring practices and obviously the moral orientation to do no harm. There is invisible abuse that goes on, and that the range of harm can be anything by a provider who focuses on exploiting patient vulnerability to actual homicide. And basically what happens is the providers transition from being a provider to being a perpetrator of crime. When you look at interpersonal violence in the healthcare arena in the United States, you see that both patients and healthcare providers are in situations where they encounter interpersonal violence, both physical and psychological. And that in fact, some institutions are buying programs to help providers become able to de-escalate situations and to intervene before violence is perpetrated. When you look at the threats against providers, there's abuse and assaults that go on. Both patients and visitors assault providers, and that the incidence is high, and nurses seem to be the highest ones that are harmed. However, the suffering that occurs affects patients, families, and caregivers whenever violence is perpetrated in healthcare settings, and obviously beyond healthcare settings. So the idea of a healthcare serial killer rather, and killing is something that is hard to get your mind around. And that in fact, when you look at the definitions in the literature, and I chose one of them, it's the unlawful killing of two or more victims by the same offenders in separate events. So that there's an intentional killing that's going on. And what seems to be obvious is that there are multiple patients killed. There are examples of singular murders as well. What happens is that the practitioner-patient relationship is violated because of the trust that physicians, nurses, and others in the healthcare basically own. They are trusted by the people whom they care for. And people also then, because of these violations, the system itself has lost the idea of trust by the community. So the violation of the healthcare providers and healthcare institutions is there. Trust is vacated. Even though some medical deaths can be classified as homicides, where there's an intentionality about the cause of death. There is also there are other examples of fraud causing death, medical negligence, gross and wanton disregard for the well-being of patients. And that end one is the most controversial if you look at that citation. So there are people who have been studying this for some time. Kaiser and Yorker, for example, labeled murder by healthcare providers a patient safety orphan, meaning in 2010, and this is many years later, there hasn't been enough attention paid to this. So this whole idea of intentionality, if you've watched enough crime shows, you know that intentionality is extremely important. And that even though there are facilities across the United States who are extremely capable of conducting and performing their safety activities, and prospectively and retrospectively looking at how to prevent errors in general, they may not be adequate to prevent murder. Even though murder is a rare occurrence when it is performed by providers, it still is something that is of serious concern. And obviously what happens, the place where the murders are committed are places where people work. And that is consistent with what we know about the murderers, that they incorporate that activity in the context of their other duties. And it's additionally hard to get past reasonable doubt because of that. Because a lot of times what is done, especially in terms of using medications, provides a lot of cause for concern related to reasonable doubt. So that the other aspect of murdering at work, the workplace, is that a lot of times people are working alone who murder. They have easy access to lethal agents and to vulnerable patients, and that in fact, death is a frequent occurrence in healthcare settings. So when you look at healthcare providers as serial killers, you know that we're proportionally represented among the serial killer population. And in fact, the serial killers are more prolific than other serial killers. The opportunity is there because of the workplace. Obviously, there need to be medical and legal responses to the murders by healthcare providers. And that needs to increase, maybe locally, if there happened to be a lawyer on the staff of a healthcare system or facility. In fact, when you look at nurses in general, and that could incorporate both RNs, LPNs, and nursing assistants, murder is higher than physicians, and that tertiary hospitals have higher murder rates than other settings. Urban locations are higher than rural locations as well. Alibis are provided because of the easy access that the healthcare providers, serial killers have to medications and intravenous tubing. It's part of their regular work. And they also are knowledgeable about death as a patient outcome and the indicators of death. When you look at the international problem of healthcare serial murder, you can see that we're not alone in the United States in relation to countries that also have been prosecuting serial killers, except the treatment of them in terms of incarceration and punishment kind of varies. And this is found in one study, but if you just start to even search on the web, you'll find this is pretty accurate. When you look at the fact that the cases aren't isolated, that there's a reporting of trouble over time, that basically is something that healthcare leaders should be alerted to. Another point is that both women and men murder, and in the case of serial killers in hospital settings, more women than men in terms of nursing commit these errors. And obviously that's kind of because the highest percentage of RNs and other staff that are considered nursing staff are female. One of the other issues is that direct care staff don't go to meetings where they say data that are aggregated or look at bar charts that suggest that intentional patient harm could be possibility going on and act as a call for attention and investigation. One of the examples and challenges is that cardiopulmonary arrests and deaths are not always explained by the acuity of patients, and that sends up warning to direct care staff because they begin to see that there was anticipated occurrence of a cardiac arrest and a cardiopulmonary death as a consequence. So that begins a little bit of a concern among the working staff. When you look at the motives of serial killers and the motive literature on this, it's really diverse, and it's hard to get quantifiable data on this. Power, control, and dominance seems to be one explanation. Maybe they want to be admired by their coworkers because they may initiate an IV that could kill a patient and then they rescue them. They could have a extreme psychological problem, a psychosis. They might also like the thrill and attention seeking by being the center of attention. They may see it as a mission because the people that they kill aren't valuable to society in their kind of explanations to themselves. And then there's sexual gratification, revenge, and so forth. Sometimes, for example, patients have resulted in anger on the part of the provider, and there may be an element of retaliation there. The end of suffering has to be very carefully contrasted with killing people at the end of life. For example, in states when that is not something that is basically considered a crime, not that they kill them, but they end their life according to the preferences of the patient at that time. And sparing suffering might be another idea that's a motive. But when you look at these, you can't just say it's one thing over another. It's difficult to extract one motive from each other. And that's why I have the point of cluster, because it's not mutually exclusive at all. So when you begin to look at some of the serial killers, you can start with Donald Harvey, who was a hospital orderly. Therefore, he had access to patients who were vulnerable. His spree lasted for a number of years, from 1970 to 87. He began working at the age of 18. And even though he said that he wanted to end the suffering of the terminally ill, he also admitted anger at the victims. And the range of ages were basically middle-aged to older people. And all, in his case, were cardiac patients. Then a more local example is Charles Cullen, who is a serial killer in the United States, as Harvey was as well. He was a registered nurse, and the numbers that are explained that by people who have interviewed him think that it's many more than 40 murders, because interviews with police and psychiatrists and journalists have suggested that many more were there. A good record of his example is The Good Nurse, that was written by a journalist, and it's a very good read in case you ever want to look at this and see some of the issues that complicated people recognizing Cullen's situation. Beverly Gale Allett from United Kingdom was murdering infants, attempting to murder others as well, when she was basically an RN, and then of course was not, in a children's ward. So that seems a little more heinous in terms of vulnerability, but everyone who's been murdered was extremely vulnerable. Then unusually, there was a team of Austrian women who were nurses' aides in Vienna who were murdering patients. And they were killing by morphine or forcing water into the lungs of patients. And since that time, they've been released from prison because, as I pointed out a little bit earlier, the punishments vary among the countries. William Hustle, former MD, was committing murder by administering high lethal doses of fentanyl to ICU patients. Even though nurses and pharmacists raised an issue with this physician, this former physician, and he was reported to boards, there was initially no disciplinary action. In this particular case, because pharmacists and nurses were complicit in this situation, they received disciplinary action from the respective state boards. He might have appealed recently as well. So he's from the state of Ohio. So it was considered an American serial killer. Niels Hogue in Germany confessed to killing 43 patients. They think that many more were there, but the question of beyond a reasonable doubt is present. More recently, Lucy Letby, a former nurse, was in basically neonatal area and was convicted of murdering 7 babies and attempted murder of 15. So she's incarcerated now. More recently, in the Commonwealth of Pennsylvania, Heather Presty, a former nurse, was linked to nursing home deaths. 19 patients of murder and 17 patients of attempted murder. And I found some of the documents on Heather from the Attorney General of the Commonwealth of Pennsylvania. So I was reviewing some of the charges, which were very interesting to see. Now, when you look at Heather, she didn't stay at one place. She was in different places where people were receiving care in long-term care and other settings like that, similar to long-term care. So I just put some of the photos of some of these people in: Donald Harvey, Charles Cullen, William Hustle, Lucy Letby, and Heather Presdy, and these are available on Wikipedia. So that's Charles Cullen, who's a more local serial murder. Hustle, the MD or former MD. Lucy Letby from the United Kingdom, who was in the neonatal area with babies. And then more recently in long-term care and related facilities, Heather Presdy. So when you look at the problem of healthcare serial murder, you can see that there are evidentiary issues. First of all, after resuscitation, and certainly after death, the evidence is destroyed. The medications might be discarded, the empty medications might be discarded, the IV lines, and rooms are cleaned after death as the physical facilities people come in to prepare beds for the next patients. When in fact people are provoking cardiopulmonary arrests and then resuscitate them, and that happens, that makes it a little bit more difficult to have an evidence trail. The other issue that's dawning is the long period of time between the crimes and the beginnings of investigations. People really don't want to think about the fact that murder has occurred. Related to poisonings, a lot of times patients who died, their bodies are cremated before murder is suspected. When, depending on where their bodies go, the postmortem exam might not be thorough enough. Evidence might be missing. Maybe the drugs that are looked at are not considered in the postmortem exam. And additionally, when patients are embalmed and buried, this complicates any toxicological evidence being used. The other issue is that drugs may be the same drugs that have been prescribed and administered as part of patients' care, or they may not have been previously prescribed, which could be an alert too. Additionally, chart data might be incomplete, missing, or contradictory, and additionally, sometimes these data are destroyed. So it's difficult to get objective data, empirical data, related to following up with an investigation. So that there is accessible objective data that's preliminary. Any kind of repeated cardiopulmonary arrest with a high rate of resuscitations need to be documented. So this is getting into the patterns that we need to look at. We also see in the details that have been described in the literature over years is that the deaths can cluster around the evening or night shifts. There is an unexplained increase in the death counts, but similarly, they may not be recorded that way. There may be multiple events in the same patient, so that there could be repeated cardiac arrest and resuscitations in the same patient. And that's a newer one that popped out to me from the literature. The other objective data might be the correlation between shifts work and higher incidence of death. So these, I think, help by providing data that could be collected and considered objective and definitely have to be considered as preliminary data. There are medical examiner report data that are available. Funeral director reports can be used as data. Self-reports are always more questionable because they're subjective. And what happens in relation to the coworkers and their reports when they are considering the fact that in fact murder could have been committed, they are suspicious of their colleagues. There are rumors that begin to circulate instead of written reports. They begin to notice unusual statistics that kind of jump out at them during the suspected coworker shift. They may, in fact, have some eyewitness kind of reports where they were uncomfortable with what they saw, and then they begin to use maybe angel of death and executor, executing the death. They might say something like about a patient, he can't die because a certain X-named nurse is not here. The nurse may predict death. For example, a nurse has said, he's going to die tonight during my shift. So when no reports are sent to supervisors, then the killers may think that there's some tacit agreement for the murder. Family suspicions are also reported and sometimes investigated, but then dropped. So when you look at the inhibitors for reporting suspicions, first of all, there is disbelief. And as I said a couple times already, healthcare providers can't get their minds around the fact that someone in their midst, as a care provider, could be murdering patients. It's an impossible idea to many. I remember when I was teaching some of my RN-BSN students decades ago, one of them shared that one of her coworkers had hit patients in the emergency room and how startled I was. And then, of course, I knew about the literature, a small amount as it was at that time, on the early literature from 76 and 85 that nurses may be considered serial murderers. The other thought is that the coworkers might say themselves that they misjudged the situation that they were seeing. Sometimes, in fact, the person they're suspicious about might be hanging around the room and watching what is happening after the death or after the successful resuscitation. They may also, as reporters, as coworkers, be concerned and feeling very vulnerable about being a whistleblower, because there's an enormous amount of literature on whistleblower activity and how people can be castigated, criticized about reporting their concern about a colleague. They also might be afraid of the colleague. Coworkers might fear litigation, and obviously supervisors and higher might fear damage to the reputation of the institution. And in some cases, at least in Cullen's example, some of the documentation was destroyed by one of the hospitals. So there was no evidence here, a trail. Maybe they're unwilling to clarify the situation, to report exactly what they think is going on, so that they might, as supervisors in this case, when it shifts to them, not report or respond to the verbal suspicions or the written reports. Not only have supervisors and coworkers at the staff level reported the suspicions, but additionally, physicians have done this as well. I'm thinking specifically of the Lucy Leppi case in the United Kingdom. I know that that was part of what was going on there, but they were discounted. Finally, they were investigated, but then that didn't lead initially anywhere in her case. So thinking about some of the strategies so that early reporting is basically considered, healthcare providers, both direct care staff and also supervisors and directors, have to suspend their disbelief and acknowledge that this is a potential that caregivers or healthcare providers could be murdering patients. And I think that we should look at maybe considering policies and procedural changes so that teams can review objective data that were suggested on the previous slide. Morbidity and mortality conferences are held. Quality improvement committees look at data. Patient safety committees look at granular data. Nursing councils might be aware of something that's going on because there's a groundswell that's happening in terms of suspicions that gets to that level. But the problem is that there is no consistent reporting of such things as cardiac arrests and resuscitations, death frequencies on different shifts, for example. So that education is needed and the investigations within a healthcare setting need to start early so that failure modes and effects analysis can be conducted by a team so that things are taken seriously. The other issue, however, is that you have to consider healthcare provider and systems confidentiality, because it is really difficult to think that you may be wrong in terms of your suspicions. And so because of that, confidentiality is a huge issue, because someone could be innocent and their reputation could be ruined for the rest of their career as a healthcare provider. So there are a lot of inhibitors to reporting again. So if you take a look at morbidity and mortality conferences, the mortality indicators are there, and a lot of times physicians would report what's going on in terms of high mortality, looking at inpatient procedures, for example, and some quality care issues. But resuscitation events might not be reviewed, in fact, they cross-referenced with deaths. An FMEA, failure mode and effect analysis, is preferred here. Another example comes out of primary care, and that is significant event audit. There's an analysis that's narrative of circumstances surrounding something that piques interest. However, it's retrospective. And so that the team that looks at this through a team-based review may have been aware, but can't do anything about, for example, a death that already occurred. But they can go forward with policy and procedure changes for that particular group and that use of that particular audit, the SEA audit. Otherwise, there needs to be ongoing statistical analysis, such as frequencies, cross-tabulations, bar charts, Pareto charts, descending order in terms of events, run charts, performance over time, percentages, frequencies by years in that case. So a lot of these charts are used very frequently in quality improvement and safety areas. So they can be applied to different committees already in existence. In relation to failure modes and effect analysis, it can be prospective, generate really long reports, maybe point through any kind of a risk index that they're using, which they calculate to faults. It's a format that can be useful to tracking items if they create any kind of a data collection format through spreadsheets and having the documentation occur there. However, it's considered by at least this one citation as being too conservative. And the other aspect of this is, even though there is evidence collected by various committees, the healthcare providers are neither police, detectives, nor are they FBI agents. And that is really an issue for all of us to consider, because we don't have the skills. And when you begin to look into, for example, FBI agents and what they've written on serial murder, and you look at such things as the crime reports, for example, Heather Presty, you begin to learn that even though there were nurse reporters in Presty's example, that you don't have the skills that really you need to follow these up from the organizational perspective into a higher level, such as the police and the FBI. I think that morbidity and mortality conferences are an opportunity, so that in fact, that near misses or errors can be looked at in terms of being interesting or unexpected, and then reviewed in relation to the provision of care and the evidence that's available. The target for M&M conferences is quality improvement, performance improvement with non-punitive review. However, the focus has been on individual accountability, and hopefully they have more of a systems analysis related to outcomes, but that too needs to be looked at. What was recommended by Lazaro et al. Is that there be an agenda that can be open to different discussions about concerns, and that in fact M&M conferences include more provider types that come to it. And I'm going to punctuate the fact that hospital-wide deaths need to be assessed, as do, I think, CPRs, and maybe a correlation between them. When you look at the availability of hospital-wide provider-based electronic mortality review systems, you can look at the death estimates that are preventable, that they have definitely hospital-wide reporting, mortality reporting systems, at least in this one article, where there's an emphasis by Mendou et al. On frontline clinical reporting being essential, and that in this study, they looked at 7 years of data, mixed methods survey, looking at all these deaths and how many at least were rated as likely or potentially providable, which is 5.2%. Very interesting and pretty current article, which suggests some process changes and opportunities for change. I just put a couple examples of charts in here that some of you, I'm sure, are used to, but here's an example of the Pareto chart, any pie chart, simple visual display with percentages, and then a chi-square without the chi-square statistic being on it, only the frequencies and the totals, just as examples to sort of stimulate the idea that we need to look at data in a different way when such things as murder or harm are suspected. So thinking about the strategies and how to support early reporting to prevent murder. A lot of employees have intranets accessible to them and that they can report errors through the intranet. This has been going on and is pretty stable over many, many institutions. There are also the committee reports, at least in Pennsylvania, because of the MCARE law, there are weekly meetings by community and healthcare provider institutional members, which look at what's going on in relation to a huge variety of errors, so that deaths and cardiopulmonary arrests and resuscitations can be added to their list in relation to safety and quality committees. When you look at the linking of variables, the associations of the variables, this needs to be done with care in terms of the reporting and also in relation to the discussions that are held subsequently. Many times the investigations are internal, and there may be an in-house lawyer team that supports the organization. At this point, it can be very problematic, especially due to the situation where the reputation of an institution in the community is definitely threatened by the discovery that a serial killer has been functioning there for some time. When in fact to report and refer to the police, the Attorney General rather, and the FBI is, I think, a serious and daunting question. So that right in here, I think there's an opportunity for change, for data analysis, for policy and procedure change, so that referral processes are smoother and people know what to do. Even in fact, maybe a process map that would help people who are direct care, supervisory, director, and higher levels to know what to do in these events. I've been studying this intermittently for some time. I first began to study it because I was doing my first study on nursing made medication errors because of my dissertation. And my dissertation, when I looked at one of the ritual categories, was medication errors. Nurses began to tell me their stories. So that's how I started to really get fascinated and have continued my fascination with medication errors and then expanding that to error in general. A colleague of mine I met years ago, Field, basically did a dissertation. He was a philosopher, by the way, before he became a nurse, on Caring to Death, a discursive analysis of nurses who murder patients. I think this is still available through the web. You could print the whole dissertation out. Both Pearson and Field then later, a few years later, you can see, wrote an article on Caring to Death, the murder of patients by nurses, worth reading. The Good Nurse by Graeber, the journalist, I refer you to. It's a really good read about Charles Cullen. Yardley and Wilson and Yorker, Kaiser, and Lampe have done absolutely wonderful work on Angels of Death. And you can see, though, by 2016 and 2006, that these are early and not that current literature. So that, I think, by itself is concerning, but I think the references are really very much worth reading. When you look at the references that are here supporting this presentation, you can see that there are empirical studies. For example, the old article 1985 by Bueller in New England Journal of Medicine. You can see that the Human Factors Handbook by Carrion is available and worth looking at as well. And then there are examples that are more popular press because of the sensationalism of healthcare providers, serial killers. Most of the literature you're going to find is not empirical, but it appears largely in the press. And so you can see that is here as well. Whenever you see a journal that has published an article on serial killer and by healthcare provider, you should be excited. But there really is not enough literature available on that. And obviously, quality improvement book, I just cited one, is important as well. ISTRA is one of the oldest articles that I found, 85 too, and I cited Kaiser and Yorker and other people whose references are worth looking at. And they're mixed along with some of the publications that have been, for example, in the New York Times about serial killers, at least allegedly, and sometimes after conviction. So it's really worth looking at this. I didn't mention Ramsden's book, even though it was cited in the presentation. And Ramsden created a red flag list. And in the study that I did with two of my colleagues, we did a parallel red flag list. But I have to tell you, I don't think the red flag list, both the one that I created with my colleagues and also Ramsden, helped that much, because there's so many variables that are listed as indicators that confirm or disconfirm serial murder commission then it might be confusing. So I think that the patterns that I mentioned on the one slide with the cardiac arrest, the cardiac resuscitation, the shift correlation, and then the combination of shift with deaths and with cardiac arrest and with cardiopulmonary resuscitation are where you should start if you want to look at objective data. So now I'm going to turn the presentation over to Kelly.
Thanks, Zane. That concludes the slide presentation portion of our program. Now we would like to begin our question and answer period. So I know there were a few questions that already came in. We are getting to those, so we'll go ahead and get started. Thank you very much for those who have already submitted questions. Zane, have you studied on the impact of geopolitical conflict, for example, Palestine and Israel conflict effects on bad actors?
I have not, but I do believe that there are opportunities for murder here, and I also have my own views on what's happening in Palestine related to the bombing of hospitals. And that's what I would say I'm concerned about. And I don't want to take it any further than that. But I think there's an opportunity for murder here.
Thank you, Zane. The next one, are there efforts at the state, local, and federal government to strengthen the mediocre legal death investigation system, understanding that the federal government is limited based on local and state jurisdiction?
I don't believe that that's the case, even though there is literature available from out of the FBI is mostly where I've located it. And I think I was thinking about how fortunate we are to be in Pennsylvania with the Patient Safety Authority, with the MCARE law that we have. I do think that we should be raising this with some of our politicians in Pennsylvania because I think we have a unique state. And that's one of the reasons why, at my age, having been looking at this for decades now and not being politically astute enough, maybe at this point, but maybe I am, to bring this to a higher level. I was thinking about taking it to our state senators and having an interaction with them because I get literature related to, voting and so forth, as many of us do. I think it needs to be raised to a different level. The evidentiary problems are always going to be of concern, but there needs to be a different look at some of the more objective data that we can basically use in terms of reporting, and an expansion of some of the committees that already exist, such as patient safety, such as quality improvement, such as mortality and morbidity, so that there can be some change in the data that are looked at and openness on the agenda to concerns like this. So I think there's sort of an action question here in terms of policy change that I've been thinking about more recently. And some of that has to do with the fact that I've been studying this for a long time, and you can figure out probably how old I am. And I want to sort of pass the bar a little bit, but I'll be very interested in anybody working with me to start to pursue this at the state level. I think it should be at the state level first because of our senators, like, for example, and maybe our representatives as well.
Thank you, Zane. So if you're looking for some volunteers, I think it sounds like maybe they could get in contact with you.
Yes, I'm in what you call preferment now, so I have more time, even though I'm pretty professionally active.
Trying to get away from the work, but it keeps following you, it sounds like.
Well, it's fun too, but yeah.
There's still some questions here. How can healthcare institutions improve their processes or policies to investigate deaths and near-death events, collecting data to compare potential risk for medical error versus intentional harm and murder?
Well, being on about 3 safety committees in the greater Philadelphia community, rather, I would say that I noticed years ago when infections began to be reported at patient safety meetings. So what I would suggest is that we start to say, let's start reporting some of these data and seeing if we can correlate them, for example, with shifts. Now, that doesn't mean that there's murder going on, because obviously the incidence of the provider is low. Not many people do it. The problem is that some of them kill a lot of people. One person is horrible, more people is worse being killed by these people. So these kinds of data collection processes are not in place from what I've been able to see anyway, and in fact could be changed, and maybe could alert someone to something that's going on. I think it's more difficult if you get into long-term care, however, and you look at different facilities that might have different reporting or regulatory, kind of overview in terms of their reporting. That could be more difficult. I think it would be easier to make these changes in tertiary care settings. It's data collection, I think, and then conversation, discussion.
Thank you, Zane. In relation to AI, is AI in use or consideration with assistance in your research?
Not anything that I found so far. I did not search it though. Now I will. I think AI could help us a lot. We could use it to advantage in relation to this. Yeah, that's a great idea. It's a great idea.
So now you're getting ideas for some stuff from this webinar, so that's wonderful. Another question is, what have you identified in your research as the type of barriers to investigating patient deaths to ensure medical error events or near death and death events?
I've also looked at intravenous errors through the reports to the Institute for Safe Medication Practices. I did a study where I looked at a lot of them, infusion-related errors, and I can say that there could be some possibilities for discovering murder in that regard. However, I'm really not too sure that we can get a good answer to this question. So repeat the question again so I can focus a little better, Kelly.
Sure. What have you identified in your research as the type of barriers to investigating some of these patient deaths? And it sounds like kind of in relation to like medical error versus the near death versus and death events.
Well, I've been studying healthcare error for a long time, and I remember I had a book out in '94 on nursing made errors, and it got through the nursing community that why was I studying medication errors and why did I do this book? And what I knew at that time was that the pharmacists knew more about this than the nurses did. And I was by that time with Mike Cohen and crew at the Institute for Safe Medication Practices. So I think that there was disbelief even decades, this is decades ago when people were not as focused on patient safety. So what I think that's great is if you look at the evolution from blame to basically being more considerate and not being accepting of everything as not intentional, because that was certainly a shift too. In terms of the just culture, for example, I think that we're already we have processes in place that we can move on some of these committees and look at the data based on what I think are more objective processes of collecting data and then correlating them. That's the answer. We have enormous amount of time spent on patient safety initiatives, and that is, I think, a good change. But I think we need to do a little bit more with the data that are available that we don't really collect. And I guess that's being redundant of what at least one of the slides suggested in this presentation.
Well, and I think to your point, that's one of the best things that you can look to is the data. And I've certainly heard that throughout this presentation. So I think that just drives home again what you're saying. So thank you.
Okay.
There's a few more questions, although the webinar will be ending soon, but we do have have time for a few more questions. So please feel free to enter things into the chat panel if you have something to ask. I know there was a question here about your thoughts regarding Redonda Vaught, the nurse from Vanderbilt with the medication error who did receive felony charges. I don't know if you want to comment anything related to that.
Well, one of the things that I do know is that she was not intentional in what happened. I think that she was judged as being reckless. There is a question about recklessness that does appear in the literature in just culture conversations. But I don't think she was a felon, frankly. Excuse me. So I'm very sympathetic toward her. However, the legal processes went where they went. And I did pay attention to that case at Vanderbilt. Other cases have been brought to me historically when I was still on the board of the Institute for Safe Medication Practices that I would review, particularly related to students who were discharged from programs. Excuse me, I'm having a hard time speaking now, so I apologize. So I would say related to that person that she suffered because of what happened and that she was judged and hopefully she'll have a more positive future related to this. But I don't think in one small study that I did, that's in one of Mike Cohen's books, I interviewed people who, just a few, whose actions related in a patient death, and the suffering that they go through never ends. It just never ends. Even though they do what you could call reparations and try to teach people about the situations that they went through, I don't believe that that they ever end suffering. And obviously the intentionality, at least in those cases, from what I could see anyway, was not there. They did not intend to harm. And I think that's true of the nurse from Vanderbilt. But I'm sure she's suffering.
I think that was this case that
Yeah.
everybody kind of
Yeah.
clung to and was following very closely. So thank you for your comment, Zane. Did you have something else to say about that?
No, I just think that that when bad things happen in hospitals, no matter what they are, that some of the efforts that are in place, like at Johns Hopkins and other places where we have training of people to be supporters of the people involved in really bad events, so that there's different kinds of supports that are available. It started, I think, out of the Midwest mostly, and I've written a little bit about that too, and some of my doctoral students have done work related to that as well, so that there's peer support and continuing other kinds of support for people who have been involved in errors and in unintentional outcomes because of practice situations. So that's the unintentional side of it and the suffering side of it too.
I have two more questions, and I know one I definitely want to end with because I think it's the crux of what this is about. But before we get to that one, how do you get better information on prospective employees' past work experience?
That is very difficult, and I think that because of Charles Cullen, that New Jersey has handled that, and other states have followed what they've done. I think that there's a more openness of reporting. You can see some of the patterns that, for example, a nurse might be moving from hospital to hospital in terms of employment. So if that's there, that could be an indicator of not just murder, but it could be of substance use and diversion, for example. So I think that if you look at New Jersey and what they're doing in terms of their reporting and their responsibility, that's a really good place to start. But it depends on the state law and local in relation to reporting this kind of activity. So I think it's tough because many times employers were restricted by the fact that they couldn't indicate, for example, that there were suspicions about a provider who left their employment. But that's changed a little bit, at least in Jersey and I think in Pennsylvania, because of Charles Cohen's murders, because of course he was functioning as a nurse between Pennsylvania and also New Jersey in different institutions. And I think from what I recall, the only thing about him that was obvious was that he was reported for medication errors, but obviously it was more than that. So it's hard to see. Employers are restricted, and you need to know what the regulations are in your particular state about this or in your particular country about this.
Thank
Disclosure.
you.
Yeah.
Thank you, Zane. I do want to, we are 2 minutes over at this point, but I want to wrap up with one final question because again, I think this gets to the crux of the content. What are the biggest warning signs of a healthcare killer?
I think when you look at their shift work and the fact that there are unexpected deaths occurring, so that the staff begin to rumble and mumble about it, both of them, that there begin to be concern. And that I think that at the direct care level, that there has to be reporting and that the supervisors and higher have to pay attention to this. Because you can tell even in Lucy Letby's case in the UK, there were suspicions. In the case of Heather Prestes, there was harm. She was reported for harming patients physically. So, there is a tension at the higher levels and also at the direct care levels that needs to be not only reported, but taken seriously when it moves up the chain of people who are responsible.
Thank you so much, Zane. This is going to conclude our webinar. Thank you, everybody, so much for joining us today.